Once we get it started, Meena,
Yes, ma'am. We are live now, ma'am.
Yes, yes.
Yes. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect welcoming you all for today's webinar, Unexplained Infertility, organized by Oxy Reproductive Health Committee. So it's my privilege to introduce the moderators of today's webinar, Dr. Aruna Ashok ma'am. Ma'am is the clinical director and senior fertility consultant at A4 Hospital and Fertility Center. Ma'am has more than 17 plus years of experience in the field of fertility and speaker at international conferences and doing research for improving fertility success rates. I welcome you, ma'am. And it's my honor to introduce the other moderator of today's webinar, Dr. Rajapriya Ayappan, ma'am. Ma'am is the Managing Director of Om Fertility Center at Srinivas Priya Hospital, Chennai. And ma'am has been the IFS Tamil Nadu past secretary and ex-committee member of OXY, Sexual Health Committee member of FOXY. I welcome you, ma'am, and I hand over the session to you.
Thank you very much. It's lovely to be having an OXY webinar. And I request our secretary, Dr. Meena, to say a few words before we start. Meena.
Yes, ma'am. Yes. Thank you, madam. So, on behalf of the Obstetric and Gynecological Society of India, Southern India, we have a reproductive health committee by Dr. Rajapriya Ayappan, madam, and Dr. Aruna Ashok, madam. So, we, on behalf of our president, Sampath Kumari, madam, myself, secretary, Dr. Meena, Dr. Meenakshi Sundaram, treasurer, and our whole team of OXY would like to have the session on Unexplained Infertility by our speakers, Dr. Sabiha Nikat and Dr. Swathi. I request the moderators to take over the session, and this will be the monthly program run by the Reproductive Health Committee. Over to you, ma'am.
Thank you. I request Dr. Sabiha to be introduced so that she can start the session.
So who's doing first?
I think I'm doing first, ma'am.
Okay.
Yeah, Dr. Sabiha would be doing it first.
Can you put Sabiha's, yeah?
Yes.
Shall I?
Meena, you want me to introduce her? You want me to introduce her? You want to introduce her?
No problem, madam. I can introduce. She is our
yeah, please.
Sabiha Nikat, our loved student. She is done her SR from Government Vellore Medical College. She is well trained in CMONG services, conducted around 100 deliveries per month, including elective, emergency, normal, instrumental deliveries, performed puerperal interval sterilization, performed MTPs, assisted laparoscopic procedures, trained in open hysterectomy, performed a variety of minor gynecological procedures, trained in colposcopy, conducted seminar classes for undergraduation. She has done a fellowship in minimal access surgery, diplomat in minimal access surgery, fellowship in hysteroscopy, diplomat of National Board in Gynecology and Obstetrics, residency from Madras Medical College, and she has undergone her fellowship training with Dr. Rajapriya Ayappan madam at Home Fertility Center and Srinivas Priya Hospital. Over to Sabiha to take over the session on Unexplained Infertility.
Thank you so much, ma'am.
Thank you.
I'll begin the presentation.
Yes. Sahiti, you can take a photo.
Sure.
Dr. Aruna, are you there? Aruna?
I'll be joining shortly.
Yeah. Okay. Thank you. Yeah, you can proceed.
A very good evening, everyone. I'm Dr. Sabiha. I'd first like to thank Dr. Rajapriya ma'am for having given me this opportunity. So we'll be discussing about the topic unexplained infertility today. One sec. Is the screen audible? I mean, is the screen visible?
Yeah, it's visible, ma. Perfect. You can go ahead.
Is gone.
Uh-oh. We are able to hear you.
Yes, ma'am. Now is this fine?
Yeah.
Yes, ma'am. So the topic today is unexplained infertility when everything seems normal. So why exactly are we discussing unexplained infertility today is because it is extremely common and least understood. It can be frustrating and can have a strong emotional and psychological impact for the couples as well as the clinicians. So therefore, we begin with defining the unexplained infertility first. The GDG from ESHRE 2023 defines unexplained infertility as when the couple fails to conceive after 12 months of regular unprotected intercourse, despite normal ovulatory function, normal semen parameters, and bilateral tubal patency is achieved. Like even normal uterine, cervical, and pelvic factors, adequacy of coital frequency, and when the woman's age is less than 40 years, and a normal testicular function and genitourinary anatomy of male. So therefore, unexplained infertility is diagnosed not when there is a presence of a abnormality, but when there is absence of any of it. So to say that to say about the epidemiology, this unexplained infertility can affect about 50 to 30% of the infertile couples, and they're most common under 35 years of age. And interestingly, about half of the couple conceive spontaneously within 3 years of trying to conceive. So let's talk and discuss about the case and see how guidelines translate practice. So Mrs. N married to Mr. M. She's 33-year-old female, married for 2 years and primary infertility for 2 years. She had a normal BMI, cycles were regular. On evaluation, her HSG was normal. The semen parameters were normal. Ovulation was confirmed by urinary LH. 3D transvaginal ultrasound confirmed normal uterine cavity. Her AFC was 16. AMH was 2.8. Her ovarian volume was satisfactory. No history suggestive of PID. Her TSH was done and it was normal. So we categorize this and diagnose as an unexplained infertility. So according to the diagnosis, we began with the evaluation. So the ESHRE 2023 recommends that evaluation must be targeted and evidence-based. So therefore, it recommends that mid-luteal progesterone or urinary LH can be done to confirm the ovulation. Although daily monitoring is better avoided, transvaginal ultrasound is the gold standard method. The HSG and HycoC can be done to evaluate the tubes as a first-line modality. Although DHL being the gold standard, it's still not the first line. For males, semen analysis as per WHO 2021 criteria is recommended, and if it turns abnormal, it is better to be repeated after 1 month and then conclude as an unexplained infertility. So to see an ovarian reserve and predict the response, we do AMH and AFC, and 3D transvaginal ultrasound can be used to get the structural assessment of the uterus, and hysteroscopy is not the first line of management. ESHRE 2023 does recommend HSG with oil-soluble contrast medium preferred over water-soluble contrast medium. This is because some RCTs have shown better pregnancy rate and live birth rate in people with almost normal to mild tubal disease. GPP says TSH can be recommended as a first-line modality. Psychological support and psychotherapy can be given when needed. To be modest, ESHRE 2023 discourages over-testing and warrants these tests only when clinically indicated. So strong recommendations claim that hysteroscopy is not routinely recommended as a first line. Endometrium scratching is not recommended routinely for such cases. To repeat, I would say MRI is not the first line recommendation for uterine structural assessment, but 3D transvaginal ultrasound is sufficient. Routine DLAB and DHL are not recommended for the low risk for tubal pathology. They can be recommended when there is abnormal HSG, when there is a suspicion of PID, pelvic adhesions, hydrosalpinx, previous ectopic, or clinically suspected or known case of endometriosis. Cervical and vaginal factors like for the postcoital test is not recommended as a routine. Vaginal and endometrial microbiome also is not recommended as a routine first line. For male, when semen parameters are normal, scrotal ultrasound has no benefit to be done as a first line. Additional tests for male like anti-sperm antibodies, no role in the as a first line. DFI, sperm chromatic condensation test, sperm aneuploidy screening, serum hormonal testing, HPV of semen microbiology, and additional tests are not to be routinely done as a first line test. Vitamin D, genetics, genomics, and thrombophilia is not recommended routinely for the diagnosis of unexplained infertility. And additionally, if TSH is normal, TFT is not recommended. So here comes the unexplained paradox where the visible causes of infertility are small, but the subtle molecular factors go submerged and they're deeper. So it's not the absence of the cause here, but it's the limit of our detection. Because tests like to define egg quality, the embryo qualities, the spermatic nucleus, the endometrial receptivity, and the immunological factors are not commonly done. To walk through the management, for our case, we always should prefer a step-up approach, wherein we saw our case coming under the category of good prognosis. So therefore, we begin with expected management, and then we proceed to ovulation induction with IUI, which is the first line of management as per recommendations. And then we step up to IVF and ICSI. So here comes the prognostic factors, wherein the good prognosis is when the age of the woman is less than 35 years and duration of infertility is less than 2 years, and she did have a previous pregnancy. It increases pregnancy rate to up to 1.8 times. And poor prognostic factors are when the age of the woman is more than 35 and duration of infertility is more than 3 years, and the endometrium is non-homogeneous and hyperechoic pattern. So the plan of choice for our case, as I already mentioned, was the expectant management. This was because it was suitable for the age and her duration of infertility. She had normal ORT. So she was, her timing of intercourse was optimized. Lifestyle optimization was given for 6 to 12 months as such, like quitting to smoke or alcohol, or decreasing the caffeine intake, and a healthy lifestyle and physical activity was encouraged. As such, expectant management provides a pregnancy rate at the end of 1 year of 27%. By the end of 3 years, it can be 60%, and by the time of 5 years, it can be 80%. So to continue the kinds of management, the next first step of active management would be ovulation induction plus IUI. So this can be taken up when there is no pregnancy with expectant management, no pregnancy with ovulation induction, and timed intercourse. And if the age is between 30 and 35, and if the short duration of fertility is less than 4 years. So here the Cochrane 2019 suggests that ovarian stimulation plus IUI doubles the pregnancy rates. It also says that clomiphene citrate is equal to the gonadotrophins, and the aromatase inhibitor like the letrozole is also as efficacious as clomiphene citrate, and IUI can be done with all of these. The live birth rate per cycle is 8%. Moving forward, the next step in the step-up approach is going to be IVF in unexplained infertility. This is the choice when the age is more than 37 years and the duration of infertility is beyond 4 years, and the couple had failed IUI cycles. The diagnostic and therapeutic quality of the IVF gives us information on the egg quality and embryogenesis. When there is a male factor, either IVF or ICSI can be preferred depending upon the cases. and a special 40 trial supports IVF and unexplained infertility. So the clinical pregnancy rate per cycle here is 28 to 29%. So if you remember the case, we had been doing the unexplained and expectant management for the case. So the expectant management did fail, and then we undertook her for 3 cycles of IUI with clomiphene citrate. That failed, and DHL was done to rule out endometriosis. The tubal patency was again confirmed, PID was ruled out, and pelvic anatomy was verified. Sperm DFI was done, and it was 16%, almost under normal category. So she was planned for ART. IVF was done following the OPU, and 5 embryos were cryopreserved, and FET was planned. But in the subsequent cycles, she conceived spontaneously before FET. So this brings us to an interesting topic, time to pregnancy. So time to pregnancy is defined as the duration where it is the duration that the couple takes to conceive spontaneously. So usually it is 12 months for normal couple, but in unexplained infertility, it is prolonged, that is about 3 to 5 years. So to say fecundability rate is per cycle is normally 15 to 20%, and the chances of conception is 84% in first year and 92% by the second year. And this declines with age and duration, and after 30 years, there is a 9% decline per year, the chances of conception. So the ESHRE 2023 encourages time to pregnancy based treatment decisions. So we have a FAST trial, that is fast track and standard treatment trial by Fertile Sterile 2010. So this brings about the conventional treatment, that is 3 cycles of clomiphene citrate plus IUI. Then if it fails, we go to 3 cycles of gonadotropins, then IUI, and then we give a 6 cycle chances of IVF. In the accelerated treatment, we give 3 cycles of clomiphene citrate plus IUI, and if that fails, we directly go to IVF, bypassing the gonadotropin cycle. This increases the pregnancy rates and reduces the time to pregnancy. And we have a 40 trial, 40 and over treatment trial. Here, higher pregnancy rates are achieved when IVF is immediately done after 2 cycles of failed ovulation induction plus IUI. And especially for women at the age of 38 to 42 years, higher pregnancy rate with 36% fewer treatment cycles in immediate IVF group was noticed. So I would conclude and give a take-home message that unexplained infertility is a diagnosis of exclusion. We better stick to ESHRE and ASRM guidelines and avoid overtesting routinely, and individualizing the treatment by age and duration. To always proceed with step-up approach kind of management, and focusing on the time to pregnancy is crucial prognostic factor, and that spontaneous conception is definitely possible in unexplained infertility. Thank you.
Thank you so much, Dr. Sabiha. So we would just take over some questions. Is it okay, Dr. Meena, to just bring in some questions for discussion?
Sure, madam. Sure. Sure, madam. So just
Yeah.
about some short forms also we would like to ask for the benefit of the delegates. DFI,
Yeah.
OPU, can you elaborate on that, Sabiha?
Yes, ma'am. So DFI is a DNA fragmentation index that gives the DNA quality of the sperms. So less than 15 is absolutely normal, 15 to 30 is acceptable, and more than 30 is severe damage to the DNA of the sperms. And OPU is ovum pickup, ma'am.
Thank you. Thank you. It was excellent, and you have covered all the details, mainly the recommendations of 2023 and all the latest relevant articles also. Madam, you can carry on with your questions.
Yeah.
Excellent, Sabiha. Very happy to.
Thank you.
See, Sabiha, when
Yes.
it comes to unexplained infertility, the crux you were trying to tell us is it's a 1-year timeline of regular unprotected intercourse.
Yes,
Then
ma'am.
you said the three key features is the patient is having normal ovulation proof, good sperm parameters,
Yes, ma'am.
and patent tubes, as
Yes.
both the genitalia are structurally fine.
Yes.
In this kind of a scenario, why it is getting unexplained is the most of the bodies are saying don't do too many testing addressing the immunological or the genetic details, because they're not going to change your style of treatment. It is just
Yes.
going to add to the expense, right?
Yes.
Now, in
Yes.
that kind of a situation, there was another interesting paper by Dr. Mohan Kamath in 2016, where he said exactly what you said, time to pregnancy. So you would take certain factors like age, duration of marriage or duration of trying, and their financial setup, right? The couple's preference is basically always based on finances. And whichever fertility center they are going, what are their limitations of treatment? They may either be having exclusively only up to IUI, or they may be having IVF ICSI services. So
Yes.
that's the key decision. And it was beautiful to note that staying calm for 3 years does help. It is not wrong to wait for 3 years. That's why your expectant is coming in line. Now, with time, I think more of testing does happen, right? So
Yes.
unexplained can get explained in tiny ways. And the key thing is, per se, that couple have a lower fecundability. That is why the time delay is happening. So normally we say majority conceive within a year. But this particular couple who are having unexplained, biologically they function slower. That's what you were trying to tell, right?
Yes,
The
ma'am.
fecundability is low. So that's where we need to wake up. A lot of times I think clinicians say all the tests are normal, so just wait. So I guess your take home message is like 30 years to 35 years of age, we have to be really careful in telling them, because that's a lot of times it happens. All the doctors said all my tests were normal, that I should just wait. So when such a situation comes, right, expectant, how long would you think they should wait in the expectant group? 6 months, 1 year, how long?
Ma'am, basically that would also be defined by the patient's keenness on the time to pregnancy. So 2 years for some is fine, 2 years for some is too much. So depending on that and the finances and other stuffs, I think 6 months to 1 year, depending upon the people, it can be offered. But if they're not willing, then probably first line of active treatment can be started if they come under good prognosis.
Right. So how many follicles would you think would be a good number to go for the IUI? Would you be happy with just a single follicle, or do you work on numbers here?
So basically, when we do IUI, we also want to increase the number of follicles and we want to optimize the cycle. So increasing the follicles does give us a better chances of pregnancy rates. So we would like two, at one or two
Yeah, at least
least.
1 or 2 should be your target.
Yes.
And since these women are normal ovulating women, we also have to keep in mind that they can have OHSS
OHSS or
on multiple pregnancies.
Yes.
So that's something we have to look at. And in your particular patient, you had said even the DNA fragmentation index was pretty good, right?
Yes.
So in spite of a lot of times, do you think stress also plays a role in unexplained? Because you got their embryos frozen and they fell pregnant.
Yes, ma'am. So stress also plays a thing, and also the IVF treatment that was given also makes a form of reset in the body. So sometimes that also adds to the spontaneous conception.
So a lot of gonadotrophins. So I think at no point we can tell a couple, right, to abstain from intercourse, right?
Yes.
So if you're fine being sexually active, do so.
Yes.
Say if you had told them don't be sexually active, we are planning FET 2-3 months later, it wouldn't have happened.
Yes, ma'am.
So that was very interesting to note that the approach to unexplained infertility is a lot of patience from the clinician side and from the couple side. But time to pregnancy is what we keep in mind. So we have to keep them in the loop, at least call them back once in 3 to 6 months to see where they stand.
Yes.
And it was also nice to say that basic evaluation is enough. You don't have to jump and do a laparoscopy or high-end testing for all of them, right? If there is a scope or if they see cancer, supposing your couple say, how can all tests be normal and I'm not getting better, doctor? Are there more tests? So if there is 1 or 2 tests which you would like to add on, what are the tests?
Definitely laparoscopy and DFI, and sometimes ma'am, I think laparoscopy and DFI are the next best
Yeah.
tests. Alongside, there are so many
Fine.
others.
So as you said, laparoscopy, would pick up mild endometriosis or flimsy adhesions. I think your hysterolaparoscopy will pick up. No, the
Yes,
subtle
yes.
things which may not be picked in just a transvaginal ultrasound. So thank you so much, Dr. Sabiha. I
Thank
think that
you,
was an
ma'am.
overview that this is unexplained infertility, and she showed with a lot of proof about what guidelines say. And this is one particular speciality of practice where following guidelines gives you a path to follow. And with that, Sahidi, we will move over to the next presenter, and I would request Dr. Aruna Ashok to come in the picture. So thanks, Dr.
Thank you.
Sabiha, and thanks to all those who have been listening to you and understanding unexplained infertility.
Thank you, ma'am. Thank you.
Yeah. Hello. Can you hear me?
Yes, Aruna, loud and clear.
Yeah. Thank you. Yeah. We have Dr. Swathi, consultant in Prashant Hospital, Chennai, here with us. She has done her MSOG from Sri Ramachandra Medical College, has done 1 year fellowship in laparoscopy and also ICOG fellowship in reproductive medicine. She has also got her awards from Professor Savitri Subramaniam Endowment Gold Medal, Best Outgoing Student in MS OBG, Young Achiever of the Year 2024 South Iconic Awards by Kalai Kadirgal newspaper. So nice. So she has been invited as a faculty also. So over to you, Doctor, for today's dialogue. Thank you for participating.
Thanks for the opportunity, ma'am.
Case presentation. Yeah.
Is my slide visible, ma'am?
Not yet, ma'am. Yes, ma'am. Now we can see your slides.
Good evening, everybody. At the outset, I would like to thank Aruna ma'am and Rajpriya ma'am for giving me this opportunity to be presenting today. And I'll be talking about unexplained infertility and what does the evidence say.
Ma'am, we cannot see the screen in full screen mode, ma'am. It is viewed as normal mode only for us. Can you try resharing again, ma'am?
Now?
Not yet, ma'am. No, ma'am. Try stop sharing and resharing it again.
All right.
And also, while sharing the screen, it is preferably to click on share screen option. Yes,
Now?
ma'am. We can see it full screen. Thank you.
So, not going much into the definition as it's already done. So, I would like to say here, unexplained infertility is mainly an exclusion of diagnosis. Most of the time, what happens is the underlying cause gets undiagnosed because what we are primarily seeing is about the ovulation, the tubal patency, and the semen analysis, and advanced testing are only reserved for individual circumstances. So coming to my case, so this is a case of a 32-year-old female who's married for 5 years with non-consanguineous marriage, regular cycles, no dysmenorrhea, a male partner of 35 years, healthy, not a smoker and an alcoholic, no medical surgical history. Clinical examination of both the partners were unremarkable. Outside, the patient had undergone 3 cycles of IUI with letros and gonadotropins, and it was documented to be ovulatory cycles and all negative outcomes. So here we had done a baseline scan which showed normal uterus size and morphology with AFC of 5 to 7 in each ovary and AMH of 2. Thyroid function test and prolactin were found to be normal, HSG normal, and semen analysis also within normal limits. So a diagnosis of primary infertility with normal male and female factors fitting into the Esri criteria was diagnosed as unexplained infertility. So we had counseled her with a stepwise approach to undergo 1 to 2 more cycles of additional IUIs, and then if failed, to think of the further IVF. One cycle was IUI is done with gonadotropins and it was negative. Patient was anxious and we had proceeded to do an hysterolaparoscopy, keeping that sometimes a mild endometriosis subtle factors could be missed when there is unexplained infertility. And so we did go ahead and do a hysterolaparoscopy and it was normal. Proceeded with ICSI with self-gametes. Standard GnRH antagonist protocol was followed, the 10 days of stimulation. Patient had 6 oocytes, out of which 4 M2s, 4 fertilized, and she had 3 embryos. Frozen embryo transfer was planned, and patient did have a good endometrium with a subsequent cycle with triple line, good zone. 2 good quality blastocysts were transferred, luteal support was given adequately, and the outcome was beta HCG positive. Patient is currently ongoing singleton pregnancy at 20 weeks of gestation. So are we justified? What does the evidence say? So my key focus of evidence today would be the ISHRAE 2023 guidelines, ASRM 2020, and the Canadian Fertility and Andrology Society guidelines of the 2019. So most of the times what happens with unexplained infertility is there are a lot of other factors which are subtle factors which are usually missed. There could be oocyte factors when there's a thickening zona or genetic abnormalities in the oocytes, when there's small abnormalities in the head and neck of the sperm, reduced sperm motility or acrosome reaction. And also sometimes peritoneal factors like mild endometriosis, tubal factors can also be seen. Immunological factors when there's any abnormal T cell or natural killer cell activity, abnormalities in the uterine perfusion can also be seen. Similarly, poor quality embryos. Importantly, even psychological and lifestyle factors also play a very important role. As investigation was already discussed, I'm going to go directly into the treatment. So what are the lines of treatment available? Expectant management, hysterolaparoscopy, ovarian stimulation, either doing with the ovulogins or with gonadotropins, natural cycle IUI, stimulated IVF. So laparoscopy and unexplained infertility, what is it? So this is the only method where we directly visualize the pelvic anatomy. So why it's done, as I said, to diagnose peritoneal factors when there's any minimal or mild endometriosis or subtle tubal anomalies. So are we justified in doing a routine laparoscopy in unexplained infertility? Definitely no benefit if the tubes are patent in HSG. Also, this is an invasive test and it does have surgical and anesthetic risk. And this should be reserved only for women who are with risk factors for tubal pathology. So this was a study which was done in Cochrane database review by Jacobson et al. In 2010, where they found a systemic review of 2 RCTs which was done and evaluated women with minimal to mild endometriosis. The intervention which was studied was laparoscopic ablation, excision of mild to minimal mild endometriosis, whether just doing a diagnostic laparoscopic alone. They did find that there was a 10% higher pregnancy rate with the treatment done and versus no treatment. So, however, what does the current ISHRAE recommendation say? Recommendations still say that it should not be routinely done in women with unexplained infertility. It should only be reserved when they do have symptoms of severe dysmenorrhea or pelvic pain, when we do see a suspicion of an hydrosalpinx on an ultrasound, recurrent failures, is only when we should think of doing a laparoscopy. And it should always not be a diagnostic, but at least a treatable one. So IUI natural stimulated cycle versus expectant management. What does ISHRAE say? The IUI stimulated cycle is recommended as the first line management, and it has been shown to have significant benefit in many cases. Why IUI? Mainly because we bypass the subtle cervical factors. We deposit a good number of motile spermatozoa near the tubes. We overcome improper coital techniques and also superovulation, where we have more than we want at least 1 to 2 eggs to improve our follicular development. So the ISHRAE recommendation is IUI with ovarian stimulation is the first line treatment, even though they don't say about using what agents like CC or letros or gonadotropins. They do say that gonadotropins slightly increase the pregnancy rate. However, the dose should be adjusted mainly to prevent multiple pregnancies and OHSS. IVF is not recommended over IUI in couples with unexplained infertility, except for special situations. When the age is more than 38 or when the infertility period is more than 4 years, or when there's any history of previous pregnancy losses or other associated factors. And in all cases, ICSI is not recommended over conventional IVF in unexplained infertility. So this is what I said. So why IVF? What is the benefit of IVF? What is the additional advantage it has? Mainly because we are able to evaluate the oocyte quality, we evaluate the embryo quality, we can bypass the subtle tubal dysfunction, which even when we see patent tubes on laparoscopy, we are not very sure is the tube really functioning, and IVF itself can be diagnostic. So the FAST trial, just quickly going through the trial. What it is this is a study which was done in the New England Journal of Medicine in 2010, where women less than equal to 39 years of unexplained infertility were studied. They were randomized into 3 arms. The conventional way being they tried first ovulogents with IUI of 3 cycles, then with gonadotropins, followed by IVF. And the accelerated arm were directly weeded with ovulogents, skipped the in-between gonadotropin arm, and IVF was done. So what was the result? They found that the median time to pregnancy was 8 months when the accelerated arm compared to the 11 months in the conventional arm. And this demonstrated a shorter time to pregnancy and also a higher per cycle pregnancy rate for IVF. So the Forte trial, this is a trial which was published in the Fertility Sterility in 2010, where women aged group between 30 to 42 years were analyzed. And they were analyzed between either going into a direct immediate IVF or versus doing ovulogents or gonadotropins. What was the study findings? They did find a cumulative live birth rate and the time to pregnancy significantly lesser with the gonadotropins, but however, because of the multiple pregnancy rate
in the swimming pool.
And this should be used only for women older or
it's
who are
some
Sahiti, can you mute all others? Sahiti, please mute others.
early IVF gives faster success. Another trial, which was known as the Amigos trial, published in 2015, where 900 women with unexplained infertility less than 40 years were evaluated. And they were studied between giving oral ovulogents versus gonadotropin IUI. And they did find live birth rate results and multiple pregnancy rate much more with the gonadotropin cycle. So the conclusion was oral ovulogents were preferred the first line due to the multiple pregnancy risk. So coming to my next case, this is a case not a very conventional unexplained case, but just to see how it goes. This is a 32-year-old female who had a primary infertility, married for 5 years, regular cycles, ovulation confirmed. Semen analysis were found to be normal, tubes normal. Diagnosis of unexplained infertility was made. Patient did undergo IVF with 2 failed attempts of morphologically good blastocysts. Patient was very keen on pregnancy, and then we did go and do her PGT for the subsequent cycle of embryos which we collected. And to a surprise, we did find 3 aneuploid and 1 euploid embryo, following which the euploid embryo was transferred and a clinical pregnancy was achieved. So are we justified in doing a PGT when there's multiple failed cycles of IVF? What does the ISHRAE say? So there is insufficient evidence to recommend PGTA to improve the live pregnancy rates in unexplained infertility. However, only consider it in older women, recurrent implantation failure or recurrent pregnancy losses after adequate counseling. And routine PGT should not be advised for women with young good prognosis. And some other treatments which are not recommended by ISHRAE are the endometrial scratch, adjunct oral antioxidant, acupuncture, and inositol therapy. And what do they recommend is psychological support, including psychotherapy when needed, and a healthy diet and a regular exercise. So unexplained or undiagnosed, unexplained infertility most of the time does have some hidden small embryo factors. There could be an aneuploidy, and a normal morphologically looking embryo or an oocyte doesn't rule out genetic abnormalities. So consider PGT after 2 or more failed good quality transfers. The approach should be individualized and it should be a shared decision making. Some articles to quote is there's a human reproduction article which is published in July 22, where they had analyzed 700 embryos from 220 cycles of PGT and IVF, and they found that in unexplained infertility couples who did undergo, there was a slightly increased chance of aneuploidy risk with balanced chromosomal abnormalities as well as segmental chromosomal abnormalities, even though there was no statistically significance shown. Another study, this is the Nigerian study, where there is the literature review, where they had analyzed about 50 articles, which showed a strong correlation between unexplained infertility and chromosomal abnormalities. And 10% of couples did have abnormalities, and the most common being translocation. So, however, we need further studies to tell us, identify what specific genetic markers are there to help us do potentially personalized treatment. So my key take-home messages are most couples who are labeled as unexplained infertility do have an underlying undetected cause. It's very important that treatment helps to increase the chance of conception and decrease the time to pregnancy. The time to pregnancy should be taken as an important parameter in analyzing to improve the gamete quality, increasing gamete numbers, and facilitate gamete interaction. ART sometimes can be both diagnostic as well as therapeutic. Evidences should be followed. Identify gamete embryo factors, any genetic factors, immunological factors, wherever required. Individualized treatment plays the key role, and we have to align with evidence. Thank you, ma'am.
Excellent presentation, Swathi. If there are any questions, I request the audience to just ask questions to Swathi and Sabiha. Nilima's message just very nice.
Thank you.
Dr. Aruna, are there any questions?
There are no questions in the chat box, but yeah, Swathi, the presentation is
Yes,
good.
ma'am.
See,
Thank you.
for unexplained infertility, can you just list out what are the tests that you will ask the patients to do for every audience to understand? Just the
Ma'am,
basic tests that you will do for anybody.
If it's unexplained, the first would be we would consider doing a DFI after an IVF cycle, ma'am, or
No. For a basic person to label as unexplained infertility,
yeah.
just
So
4
basic
or
test
5
would
tests
be
that you do.
so the basic test would be one is to for the male would be a semen analysis. Female we need to find out if they have good reserve and document ovulation. 3 would be a tubal testing either done by an HSG or a saline sono. So these are the 3 basic tests which are done. Additionally, when they have any failed cycle, we can think in terms of hysterolaparoscopy just to rule out any mild endometriosis or subtotubal factors, and a DFI can also be done in special situations.
There's one more question. How to decide on CC and letrozole? Swathi?
There's no clear cut, even though ASRM guidelines 2020 did favor in terms of CC, SRA does not say what is more beneficial. Either of the agents can be used. All they recommend is going ahead with a stimulated cycle of IUI to get better results. Or ovulogins can be used in a younger age group people. Either of them don't have additional benefit over each other. However, when we think in terms of when there's thin endometrium, because of the anti-estrogenic effect of CC, letros is slightly more preferred nowadays.
Okay. About the Hanol score, have you ever used the Hanol score or tried it for at least 1 or 2?
No, ma'am.
Because the score was used for that. For IUI, but now these patients taking up the procedure is very fast. But it help us tell whether the patient has a prognosis. This will be useful. And whether they have the motor.
Aruna ma'am, your voice is breaking, ma'am.
What is the benefit of adding HMG to CC or letros cycle? Swathi?
Of course, adding gonadotrophins to the IUI cycles, they do have a slightly increased better pregnancy rate when compared to giving only oral ovulogins. But we should also keep in mind the multiple pregnancy rates. And when using gonadotropins, they should be used at a very much lower dose with careful monitoring of less than 75 units. This is what is the current recommendation as per the SRA. Can be used, but with caution and multiple pregnancy.
There is one question with. Yeah, but there is a question for all seniors. 41 years, female, 8 cycles of IUI failed. Diagnostic laparoscopic patent tubes, no significant findings. Male partner, normal semen parameters, different DFI normal. 1 cycle ICSI, 9 oocytes, 1 fertilized, FET negative. How will you proceed next? 9 oocytes, 1 fertilized, and embryo transfer. I think it's 1 embryo and the embryo transfer became negative. I think there is a Dr. Dhanvarsha. Okay. You wanted to answer it, Swathi?
Mm.
This patient is actually a 41 years. So the number of oocytes, if we calculate, there is a calculator called oocyte calculator by Merck. They have sponsored it. Before ART calculator need to be paid and you have to get the subscription. But now it is available freely in the Google, so everybody can use it. So the number of oocytes required at 40 years to form 1 euploid embryo is almost 30 oocytes, 30 mature oocytes. So only when you get 30 mature oocyte, you will be getting 1 euploid embryo. And that 1 euploid embryo becoming a live birth is the next scenario. I think the 41 years is a major determinant, and we cannot call her as unexplained more than 35 years because advancing maternal age is itself a factor which can contribute to infertility. I
Ma'am,
think 41 years you have
that
to counsel about the factors.
sorry, ma'am. That ICSI was done when she was 37 years, ma'am. That was almost 4 years, 5 years back.
Okay, the
But
first option for the patient, we can try another IVF cycle for her, but you have a IVF success rate calculator also available by CDC. Once you put the calculator in front of the patient and patient understands the success rate of her age with the self and donor oocyte, and she herself gets convinced about the donor oocyte, you can proceed with that. If she insists on her own oocyte, based on the AMH, you should advise her embryo pooling might be required. And if you are going to do IVF, do a genetic testing for embryo and then transfer the best embryo possible because already she has failed one.
Okay, ma'am. Thank you, ma'am. Thank you so much.
Yes. Swati, about the dosage of HMG that you use for IUI cycles for the audience to understand, what is the dosage that you start with and how you schedule it with letrozole and HMG or letrozole and FSH?
Ma'am, it can be either done together or in sequential. What we follow is
Okay.
giving 5 days of Letros, 2.5 mg 2 times daily, followed by we give 75 units of HMG, and then we 2 doses on day 8 and day 9, and then we follow up and see how the follicle is. If we wait till lead follicle reaches about at least 20 mm, 18 to 20 mm, preferably a little more, 8 to 20 mm, and till that we keep giving the dose, ma'am. This is what we follow.
Okay. In this, actually, have you ever tried dosage of 37.5 in your patients?
No, ma'am.
No. But what in experience we have found out for the last 2 years after the sonal punctures, the Doppler parameters which we started using,
Yes, ma'am.
37.5 is enough for many of the patients to form 1 or 2 follicles. In
Okay.
IUI cycle, 37.5, if you start using on 7 and 8, maximum 5 doses will be required. And everyday dosage is required because the half-life is so.
Yes, ma'am.
So if we give whatever the FSH or HMG, this much of dosage is enough for many of the patients. Though some patients are resistant and they require 75, and our dosage of 150, which we were using many times before, had come down to at only 1 or 2 patients per month, and every other patient gets response with 37.5 and 75 itself. So
Okay.
this may be useful in your practice to reduce the expense for the patient also.
Yes.
Can IUI be performed in endometrioma? If the tubes are patent and you have a ovulation documented, definitely IUI can be performed in endometrioma because still the endometrioma patients have a chance of conception. It is not that if the tubes are patent, you can definitely proceed with the IUI. Dr. Durga has asked this question. And Dr. Neelima Talari has asked 0.5 AMH. Any protocol, irrespective of age, as 27-year-old, also having AMH 0.5. What do you wanted to comment, Swati? After that, I can tell. AMH of 0.5, what you wanted to do, they have asked.
We can use conventional. Otherwise, we could, if cost is a factor and we are not very sure how many embryos we would get, we can also try mild stimulation.
Yeah. You told about IUI, otherwise IVF, huh? What did you tell? Correctly, I can't. Yeah.
Conventional stimulation can be tried with higher doses of Gonadal tropin
Okay.
or mild stimulation can be right, keeping the cost benefit of cost. Will
Okay.
do anticipate a load, but 0.5 we should be able to do with
Okay.
control.
Will you not try IUI for this patient at any time?
We can explaining the prognosis, maybe 1 to 2 cycles of IUI we could try.
Yeah, definitely.
Yes, sir.
I think when a patient comes with 0.5 also, if she's 27 and not tried properly for 1 year also, we will wait. Try them with a ovulation induction and follicular monitoring for 2 cycles, if not IUI, and then only we'll go for IVF, because even 0.3, 0.4 has conceived. But
Yes.
as Dr. Swathi has rightly told, counseling the patient about low ovarian reserve. That's very important. And regarding mild and wild or mild and conventional stimulation, the Poseidon 1 and 2, there is a use of increasing the dosage. Whenever there is a Poseidon 1 and 2, the patient has got some polymorphism. So
Yes, sir.
only in the previous cycle, they have not got a good response. So when you have a Poseidon 1 and 2 patient, you can raise the dose by 75 U. But if you have a Poseidon 3 and 4, like this is a Poseidon 3.
3.
So Poseidon 3 patient, whether you increase or not, that much only is the eggs that is there. So by increasing dosage, you will not get more eggs. By repeating a cycle, you will get more eggs. So that is the difference between Poseidon 1 and 2 and 3 and 4. 1 and 2, you increase the dosage in the next cycle. 3 and 4, you just do repeat cycles, because whatever you increase, that much only is there will come. So regarding the mild and the conventional stimulation, this is difference according to Poseidon. I think due to age, should we plan IVF ICSI or can try IUI? Definitely. Oh, married for 2 years. Another doctor has asked. Female is 41 years. See, age is the most important criteria for any success rate. So AMH is 4.5. Definitely this patient, after 35 years, married for 6 months itself is indication for treatment. This patient is ideal candidate for IVF and not a candidate for IUI. More than 38 years, it is not advisable to carry on with IUI because age is the most important determinant for live birth rate. So even when the patient is 27 and AMH is 0.5, we are arguing that still patient has natural cycle IUI chances. But even if AMH is 4.5 and the age is 41, we have to choose IVF because the time that she has to have a baby is very less. I think this is the what world standard tells and evidence tells. Yeah. I think it was a very fantastic discussion that we had, and everybody is actively putting in questions. Very happy to see it. So, unexplained infertility, I feel most of the unexplained infertility will have explanation once you do IVF. We had once a patient who had 12 cycles of IUI. I keep telling this to many of the patients. 12 cycles of IUI, everything was fine. She was arguing with me for IUI cycle again. But we told you should go for IVF, otherwise there's no use. And every other oocyte has double zona. So which follicular monitoring or which test will find out double zona for a patient? So sometimes the patients have some problems which cannot be found out in the regular use, so we should use it. And somebody, Neelima has asked, lymphocyte transfer, is it beneficial? What is lymphocyte immunization therapy? They have asked, I think. LIT, is it
Yes,
beneficial?
ma'am. I think they're asking.
In unexplained infertility or recurrent pregnancy loss is the most important thing that you have to do. Recurrent pregnancy loss, if there is a HLA matching of more than 3, then we give LIT for the patient. It is showing us very good success rate and very good improvement. We tried one arm with IVIG, but the success rate was not very great. But with LIT, we have very good success rate. So only when patient who has high matching, you do LIT, it will be useful. Not for a normal patient, you do randomly for any patient with unexplained infertility or RPL, it will not work out. When you identify a population who needs LIT and then you subject them to LIT, it works well. I think that's all the questions. So many of the patients have a problem. The unexplained infertility as such is only 5%. It is not 50%. I think more we test and more test is going to come in future. We'll find out answers for more of the problems that we have. And we all should have lots of research mentality to improve it. One more question has come from Dr. Durga. What is the advantage of adding letrozole to clomiphene induced after 5 days of ovulation induction? Okay. You wanted to answer, Swathi? Dr. Swathi? Able to hear me?
Yes, ma'am.
The question is, after clomiphene, letrozole, what is the use?
Adding it was not much of a benefit to add letrozole after 5 days.
I don't know whether we have combined therapy like that,
Mhm.
but we have done a study 10 years before about clomiphene and letrozole therapy, where clomiphene acts first initial half, and the next initial half we have the letrozole acting up. And we had multiple ovulation when these patients were studied. Multifollicular development is prone in these cycles, it is very prone. Maybe for patients who are not affordable and PCOS is very resistant. There are articles where they're using clomiphene for 5 days and then letrozole for 5 days. There is studies which are being published. We tried it 10 years back, and after that, I've never tried it. When I was a fellow, after finishing the fellowship, we wanted to do a study, so we did this. It is useful and cheaper alternative, but people should publish the study, I think. Thank you for the fantastic audience. Thank you, Oxy, for
And there is
giving
one more
this
question.
platform.
Lymphocyte transfer, is
Yeah,
it
madam.
beneficial? Lymphocyte transfer?
Yeah, madam, we answered that. Lymphocyte,
Yeah.
I think it is
Yeah,
LIT,
yeah.
lymphocyte
Yes.
immunization therapy. We answered that question.
Yeah.
RPL,
Excellent
when
discussion.
recurrent pregnancy loss, when HLA matching. Yeah,
Yeah.
nice.
Excellent discussion
So,
today
yeah,
on unexplained
yes,
infertility.
thank you,
Lot
thank
of
you.
take-home messages.
Infertility.
Thank you. Yeah. Thank you
Okay,
so much. And
thank you,
on behalf
thank you.
of all
Thank you, ma'am.
Reproductive Health Committee, we would like to thank Dr. Rajapriya Ayyappan Madam, Dr. Aruna Ashok, and the excellent speakers Sabiha and Swathi. Thank you all the delegates
Thank you,
and
Doctor.
Sahiti for having given the platform. Thank you so much.
Thank you. Thanks a
Thank you,
lot.
ma'am.
Yeah,
Thank you,
bye.
ma'am.
Thank you.
Thank you.